This short podcast is intended to recap the material we discussed in preparation for our first lab. The purpose of the lab was for you to see firsthand how to measure blood pressure and heart rate, and to observe how they change in response to different levels of exercise. Hopefully you found the procedure to be a little tricky to grasp at first, but with a little practice felt relatively comfortable doing it. Hypertension, because it's not something you can outwardly see, is important to determine because it's so strongly linked to heart disease, the leading cause of death in the United States. In fact, in preparation for this podcast, I learned that 1 in 4 deaths in the U.S. are attributed to heart disease, or 600,000 deaths per year. A simple blood pressure measurement can greatly assist in determining if a person is at risk for heart disease and then take action to reduce the risk. We learned that there are 4 classifications of blood pressure. Normal, which is classified as less than 120 over less than 80. Prehypertensive, 120 to 139 over 80 to 89. Stage 1 hypertension, 140 to 159 over 90 to 99. And Stage 2 hypertension, which is greater than 160 over greater than 100. The higher the number, the more risk a person incurs. The prehypertensive category is a relatively new one, and its purpose is to warn a person to change his or her lifestyle to avoid becoming hypertensive. We mentioned that increasing physical activity, reducing obesity levels, eating a better diet, which includes reducing sodium, and leading a lower stress life are examples of how to do this. Some individuals, if lifestyle modifications are not enough, are put on medication to reduce blood pressure. These medications include vasodilators and beta blockers, which act to increase arterial dilation and reduce heart rate. Because of the side effect these medications can cause, it's preferential to address hypertension concerns with non-pharmaceutical options, but this isn't always an option. A blood pressure measurement comprises 2 numbers, a systolic or top number and a diastolic or bottom number. The systolic number represents the maximum pressure in the arteries and occurs when the heart ejects blood. The diastolic number is the minimum pressure in the arteries and occurs when the heart is filling up with blood. For this reason, the systolic number will always be the bigger of the two. In relation to categorizing a person's risk, if either number is high, it's a risk factor. So from this perspective, it's not appropriate to say that the systolic or diastolic number is more important. However, because the systolic number will fluctuate in relation to heart rate more than the diastolic number, multiple measurements over a period of time should be taken in order to truly classify someone. For example, if a person is nervous when being measured, has exercised recently, or has had a large amount of caffeine, it can trigger a higher than normal systolic number. As I said earlier, blood pressure is not very difficult to measure, but it takes practice. Blood pressure is a valid measurement of heart disease risk, but in order for the measurements to be reliable, a few things should be addressed. First, the arm should be level with the heart. Having the arm above the heart will lower the reading, and the opposite is also true. Second, the cuff should be placed snugly around the upper arm, just above the antecubital fossa or crease of the elbow. The stethoscope should be placed just below the cuff, in line with the brachial artery, which runs along the medial or inside part of the elbow. You can find this spot by feeling for the tendons under your biceps and then moving your fingers towards the inside of your arm to a halfway point between the tendons and the bone on your inner arm, your medial epicondyle. Pump the cuff up to between 140 and 180. The purpose is to have a value that's above a person's suspected systolic blood pressure. Release the pressure at a slow rate, between 2 to 5 millimeters of mercury per second. Going too fast will lead to an imprecise measurement, and going too slowly will be uncomfortable for the subject and may elevate blood pressure. By controlling the release of pressure with the valve, you should try to release the pressure at a steady rate. When you first hear the subject's heart rate through the stethoscope, make a note of this value. This represents the systolic blood pressure. Keep listening as you release pressure from the cuff. When you can no longer hear anything, make a note of this. It's the diastolic blood pressure. As you might expect, your resting heart rate and blood pressure levels will change when a person begins to exercise. In fact, the harder a person exercises, the higher their heart rate and systolic blood pressure will get. There is a linear relationship between exercise intensity, heart rate, and systolic blood pressure. But because the diastolic blood pressure is the minimum pressure in the arteries, it doesn't typically change in response to exercise. When an exercise bout is ended, a person's heart rate will gradually return to normal, between 60 to 80 beats per minute. The systolic blood pressure, however, will often fall to levels below normal resting levels. This is because during exercise, your arteries will dilate to accommodate increased blood flow. The arteries remain dilated for a significant period of time after exercise, and this fact, coupled with a reduced heart rate, causes a lower than normal systolic blood pressure. Speaking of measuring heart rate, which artery should be used? By convention, the radial artery, located on the thumb side of your wrist, is used because it's not an invasive measurement and it's easy to measure when someone is exercising. The carotid artery, located in your neck, can also be used, but it's more invasive to measure, and pressure on this artery, particularly during exercise, can cause a person to pass out due to lack of oxygen to the brain. Best to stick with the radial pulse. Just be sure not to use your thumb when measuring, since your thumb has its own pulse. Instead, use your index and middle finger. Count for 30 seconds and multiply by 2 to get a resting heart rate, and count for 15 seconds and multiply by 4 to get an exercise heart rate. The last thing to finish up with involves how to properly use a cycle ergometer. These specialized exercise bikes are used in research and teaching labs and are designed to provide accurate data if they're used properly. One of the most important things to do with them is to calibrate them before starting. This simply involves removing the tension from the flywheel and aligning the zero on the pendulum with the resistance indicator on the bike. It's a little bit like a bathroom scale. If you're not standing on it, it should read 0. Such is the same for the ergometer. The two ways to control for intensity on the bike is to modify the resistance on the flywheel or to have the subject pedal faster or slower. Resistance and cadence. Cadence is controlled using a metronome. Simply set the metronome to desired cadence and turn it on. The subject then matches the clicking cadence by the metronome. It's not easy to do at first and takes a little practice. Resistance is set after the subject begins pedaling. Turn the resistance knob clockwise and watch the pendulum swing to the desired resistance. Quantifying intensity involves accounting for both of these variables. With the cycle ergometer, wattage can be determined simply by multiplying cadence by resistance. A person biking at 60 RPM at 2 kilograms of resistance is putting out 120 watts. The other unit of intensity or workload on the bike is kilogram meters per minute. On the ergometer, this is determined by multiplying resistance by cadence by flywheel distance. On the cycle ergometers, the flywheel distance is 6 meters. So our example person has a workload of 720 kilogram meters per minute, or 60 times 2 times 6. That basically covers the majority of material you should understand for our first lab. Refer to your class notes and your textbook to get more detail on these topics.